The South Carolina ADAP has three components to the ADAP. We have a direct dispensing program whereby we dispense medications to patients directly through a third-party contract pharmacy. We also have an insurance assistance program where we will assist patients with their premiums, copays, and deductibles. And we have a Medicare Part D assistance program very similar to the insurance assistance program except specific to Medicare Part D. So regarding implementing cost containment measures, we have had 2 periods of wait lists for our direct dispensing program, and that's been our primary cost containment measure that we've implemented. 2006 and 2007, we had a significant wait list. With an influx of funding from HRSA and state funding, we were able to remove that waiting list. Unfortunately, we had another waiting list again in 2010, 2011, and this first part of 2012.
When we put a list of cost containment strategies, you know, you could, in a small state like ours, you can't do every single cost containment strategy just because you don't have the administration to do so. And so really taking a look on what you're going to get the most bang for your buck.
When deciding to implement cost containment measures, we only focused on the direct dispensing program. Because the insurance assistance program and the Medicare Part D assistance program both generate revenue, it didn't make any sense to limit the number of patients into those programs. And we went to a wait list because other cost containment measures really weren't feasible since our formulary was already so lean. We just didn't have a lot of other things we could turn to contain costs.
We've always operated a very, very bare bones program, and so there weren't a lot of cost containment strategies to implement.
What we do is new applicants whose income is at or below 125% of the federal poverty level are enrolled in the program and able to get medication through ADAP. And new applicants whose income is between 126 and 300% of the federal poverty level are placed on our waiting list. Now, by virtue of being on the waiting list, many of those clients are automatically eligible for assistance through the patient assistance programs sponsored by the pharmaceutical companies or some other programs around the state. So a lot of the clients on the waiting list are able to get access to medication.
The other thing that we did a little bit better in '09 was the waitlist management and checking back in with our case managers to see what was going on with those folks that were on the wait list and really ensuring that they had their medications, they were receiving their medications elsewhere. Whereas in '04 we just assumed that. So we really wanted to kind of do a better job with waitlist management.
During the first waitlist, we learned a lot that helped us during the second waitlist. And in terms of the impact to the program, it really, I would say, almost more adversely impacted our service providers and the HIV care system, because as the ADAP, we were able to manage the workload. It really wasn't any additional work. But for our service providers who were then forced to turn to other sources to get medications for their patients, they were having to sort of focus on those efforts. Therefore, multiple services were going undelivered. So while we had great success in ensuring that the patients on our waiting list were accessing medications, there was other services that weren't being delivered.
And then going back to the challenge of tracking clients, since we've been forced to have to do so much more checking in on clients, we've learned how to better handle that task as well. We spend a lot of time on the phone with clients, on the phone with their case managers or the providers, and because of that, we've found a lot of clients who were lost to care and been able to move them back into care. So again, it's not a great thing that we've had to deal with these cost containment measures for so long, but we've really been able to make some major improvements to how we manage the program. We run a leaner, more efficient program than we ever have.
We did, from the ADAP perspective, one of the impacts we found was that the program, during the period of a wait list, our cost containment, the program is under a microscope. So any communication or any messaging that goes out had to be very carefully crafted, and we had to really work real hard around that and just communicating with the community about our projections and how long we think the wait list is going to be in place and the numbers of people it's impacting.
One of the biggest things when you close your program to new enrollees is that a lot of people want to know why this happened, why you think you didn't mismanage funding, so you've got to present a lot of data to a lot of people.
People wanted data about the wait list, including how many in my county, how many at my agency. That was one of the lessons learned, was that during the period of the first wait list, we were sort of foolishly optimistic that this wasn't going to play out over a long period of time. So as we were accepting applications and putting people onto the wait list, we kept a rather unsophisticated spreadsheet with a few basic data points in there. And the wait list mounted to over 600 patients. And it was hard to get any real meaningful data out of that spreadsheet. So when we were forced with the cost containment situation in 2010 and had to implement another wait list, we had learned that we were going to need to be able to access the data. And so we worked with our software provider. We used Provide Enterprise. We worked with our software vendor and built a certain status in our data system, for ADAP waitlist. And that allowed us to run really any kind of report you would imagine. So at any time during the waitlist, we could tell anybody, where do these people live? What's their income level? What's their demographic information?
We manage and analyze the enrollment data and cost data and utilization data on a monthly basis. In fact, some of the enrollment data we track on a weekly basis. So that's a big change and a big improvement. We spend a lot more time and energy on using that data to check our projections and to readjust any projections moving forward.
But really the communicating with the community, communicating with legislators, communicating with the powers that be in our department was the key for both situations, and really helped us to get through both situations. Also, our contractors and the community that was serving the clients, we did hold calls with them. I think that that's one lesson that we learned from '04, and we did a better job of that in 2009, and that was to really communicate with the people that were serving the clients on a more regular basis and send out regular emails and have regular conference calls to let them know what was happening.
Well, one thing I would say overall that we learned, a lesson learned, is the importance of diversifying. So that probably 6 or 7 years ago, 90% of the patients we served were in our direct dispensing program. Now we have 30% of our patients in our insurance assistance program, which is a revenue generating program. And we've got another maybe 7% in our Medicare Part D assistance program. So we've sort of shifted those proportions. And the insurance and the Medicare programs generate revenues that then support our direct dispensing. So the diversity of our ADAP portfolio has really, really helped us and really was the game changer in being able to remove those cost containment measures.